Hello everyone. My name is Joe Becker. I'm a physician in the Division of Emergency Medicine, Department of Surgery at Stanford University. Today we're going to talk about acute stroke symptoms, and acute stroke management. So without further delay, we'll start with a case. The case is that of a 62-year-old male. He's brought in by his family one after he was being found in bed, and he was noted to be unable to speak coherently or communicate, and was not noted to be moving his right side. His family's not sure when the last time they saw him normal. They kind of woke up and found him in this state. All right, so just to review, as in prior lectures, we've gone over the emergency medicine approach, which is a little bit unique in that it is a triangular approach to patient care. We, of course, start the interaction with the patient by evaluating them, but then we either sometimes have to proceed immediately to action to try and stabilize a patient or potentially save their life. And then occasionally it is also appropriate to think about the patient's case, their presentation, and what the best course of action is. And so sometimes you'll see throughout this presentation that it makes more sense for us to consider the patient, to stop and to think about the case and develop a differential diagnosis or consider other interventions. At other points, it's more appropriate to act immediately, perhaps without a complete picture of what the patient has, including their diagnosis. So as part of the evaluation, the initial assessment, as we've done previously, we're going to start the assessment of the patient by a general assessment of their condition. In other words, their LOC, or their level of consciousness. And in this case, the patient appears to be alert. He's lying supine in the bed, but he does not seem to be able to communicate with you and is not attempting to speak. Our assessment of the airway, it appears to be patent. The patient seems to be able to breathe adequately. When we assess the chest, the patient has good breath sounds and is clear to auscultation and seems to have no difficulty in breathing. And then, of course, to finish off the ABCs, we assess the patient's circulation, or their pulses. And we note that this patient has present radial and carotid pulses, as well as good capillary refill, and his extremities are warm to the touch. All right. So as we begin most of our interactions with patients in emergency medicine, we perform a general assessment of their ability, of their level of consciousness, as well as their ABCs, or their airway, breathing, and circulation. And this is kind of the foundation of how we begin our interactions with patient in emergency medicine. So as you see, the heart rate is 78, and this is a normal heart rate. When we assess the patient and his pulse, and of course his cardiac examination, the rhythm is regular. The respiratory rate is 24. That's perhaps slightly tachypnic, but also within the normal range. Blood pressure is elevated. The systolic pressure is 170, and the diastolic pressure is 108, and that is high, and we'll discuss that more in a second. The oxygen saturation is 98% on room air, and that, of course, is normal too. And the temperature is 38.6 degrees Celsius, which is, of course, also normal. So having evaluated the patient, they seem to be quite ill but stable, so it is appropriate to continue to think about the patient, and this is our initial assessment. So what we found so far is that the patient seems to be unable to speak. It as well seems through the history that the patient is not using his right side. We've also found that the patient is quite hypertensive and his blood pressure is quite high. So is this patient sick? And this is a central question in emergency medicine that we've kind of encountered in the other cases that you've heard so far, and perhaps this is the crux of the determinations and the decision making that we need to make when we actually assess a patient. And the answer is yes. Now, when you think of if a patient is sick or not, many times you are thinking about the vital signs, and certainly that is often appropriate if a patient's vital signs are showing any signs of a dangerous situation, then certainly that patient would be sick. But in this case, it's more the patient's clinical condition and presentation that indicates to you that they have a very serious medical problem that demands your immediate and focused attention. So when we consider our immediate interventions, we can do several things, and many times these are important to perform early in the interaction with the patient because they can be stabilizing and potentially life-saving. A few of the immediate interventions that we perform in emergency medicine are listed here. We may position the patient to allow them a greater degree of comfort or to improve circulation. We may also control bleeding by applying pressure to a site that is bleeding. Sometimes it is necessary to perform cardiopulmonary resuscitation in a patient who has no pulses. Other times, we may provide defibrillatory electrical shock to a patient to restore a perfusing cardiac rhythm. Oftentimes, it's very important to open an airway by providing either a jaw thrust or chin lift in a patient if that is appropriate and they're not a trauma patient. Sometimes we can provide oxygen to a patient to improve their oxygenation and their respiratory function. Other times, we need to actually breathe for the patient and give them bag, valve, mask respirations. We can also place the patient on a cardiac monitor, as is sometimes important if we are concerned about cardiac arrhythmias or their overall cardiorespiratory function. Many times it is necessary to place either one IV or multiple IVs to provide IV fluids, blood products, or medications. And finally, it's of critical importance to check a blood glucose in many patients who present with any form of confusion, focal neurologic findings, or depressed level of consciousness. All right. So in our patient, we've been able to determine the patient does not seem to be able to speak. He also seems to have right-sided hemiparesis weakness. So immediate actions include, of course, checking the fingerstick blood sugar or the rapid blood glucose test. And this will be very important because this is a very easily correctable, potentially dangerous diagnosis that we can identify and address very early in our interaction with the patient. As this patient seems to be quite ill, and we've already decided that they are ill, it's going to be necessary to establish IV access in this patient. That is also something that we should act and do very early in the patient interaction. As well, this patient should be placed on a cardiac monitor. Patients who have focal neurologic findings and perhaps stroke can manifest multiple cardiorespiratory derangements, and as such, they should be placed on a cardiac monitor so we can very closely monitor their hemodynamics and their cardiorespiratory function. So again, I want to review the emergency medicine approach in a patient, which consists of an initial evaluation, followed by either thinking about the patient and considering their diagnoses, perhaps a differential diagnosis, and the best way forward. Sometimes it's actually more appropriate to act first, to intervene on that patient, to improve their clinical condition prior to considering their case in a more in-depth fashion. That is oftentimes not the end of the kind of patient care cycle in emergency medicine, and we have to reevaluate them and then consider, think, or act again. And this is because patients change while they're in our clinical care. A patient that comes in a stable condition may eventually deteriorate and not be stable, and thus require us to reevaluate their condition and determine if anything has changed or if perhaps we missed something on our initial evaluation. Subsequent to reevaluating the patient, we hopefully have a better idea of their clinical condition and a better idea as to the most appropriate disposition of the patient. In other words, what we do with them, where do they go? Do they go home? Are they admitted to the hospital? Or do we have to transfer them to another facility for a higher level of care? All right. Now, the emergency medicine approach, as I said, as we've discussed, starts with an evaluation. And the components of the evaluation we've discussed a little bit already, including the vital signs and the ABCs. We also perform what is known, and I think what you've encountered so far in this course, as the sample history and a focused physical examination. And this is essentially a focused history and physical examination that allows us to kind of drill down onto the problem that the patient is presenting with to really kind of have a good sense for our thinking or our acting as we may need to do in the patient. All right. As we proceed, if we are considering the patient's condition, that mostly consists of a differential diagnosis. In other words, as you've learned, a list of the possible diagnoses that could be producing the clinical symptoms in the patient that you see in front of you. This is a very important step because developing a complete differential diagnosis really allows us to not miss different considerations and not miss diagnoses that may be life-threatening. And then lastly, we act, and that consists of either treatment, some of which we've talked about before in our immediate interventions, or diagnostic testing. In other words, tests that we can obtain to help us more clearly elucidate and kind of detail the differential diagnosis that we developed when we thought about the patient. The sample history consists of symptoms, allergies, medication, the past medical history, the last meal, and the events surrounding the patient's presentation. So this is a fairly comprehensive, cut and dry history of the reason that the patient is in the emergency room. All right. Now, In this patient, our sample history is, the symptom is that this is a 62-year-old male. He has difficulty speaking and apparently swallowing, and as well now right-sided weakness. The pertinent questions related to the symptom are the following. One, we need to have an idea of the onset of the patient's symptoms. When did this start? And in this case, it sounds like the patient was discovered in this condition, and so it's not really certain when it started. And given the patient's inability to communicate, we are unable to learn from the patient if he knows when this started. We also like to know the timing. So in other words, has this patient had similar episodes in the past? Is this something that has happened before and perhaps has been worked up in a medical sense, or is this the first time the patient's having this problem? And then U for unifying, is there a medical history that can unify this patient's multiple findings into one coherent diagnosis? So in other words, in this patient's medical history, is there a history of something that would perhaps shed some light as to why this is happening? So for instance, substance abuse, or was the patient hit by a car the night before? Something very relevant that could allow us to at least prioritize a little bit the differential diagnosis list that we're going to develop. Lastly, we'd like to know the course. Is this patient improving or worsening? And that is important for a few reasons. One, we'll need to know to be prepared. If this patient is worsening, then perhaps we should be prepared for deterioration in their condition and thus marshal resources for resuscitation or perhaps other interventions. And two, if the patient is improving, we want to keep a close eye on them and really monitor their clinical course to see if they return to normal. All right, so continuing on with the sample history, we see that the patient has no allergies. He is on medications to control blood pressure, so that is helpful. He's certainly very hypertensive here in the emergency room, and so it appears as though he already has that diagnosis. He's taking some medications, but we are unclear as to which ones. All right. Regarding his past medical history, again, he seems to have hypertension, and so that fits with the presentation as well. The last meal was dinner the night before, which is roughly the day before, so about 12 hours perhaps in this case. And the events surrounding this presentation, there really are none. The patient seems to have been in his normal state of health. There was no trauma, no recent fever or other symptoms that led up to this presentation this morning. So the physical examination, of course, is a very important part of our assessment of the patient in emergency medicine. However, in emergency medicine, it's oftentimes important to perform a focused assessment or physical exam of the patient first. And we frequently focus this assessment based on the patient's presenting complaints. So in this case, the patient has an inability to speak and cannot move the right side of his body. And so given this, it is important to consider, of course, the neurologic examination. And that is a part of the physical examination that is very important, and certainly in this case will be important. However, we also want to consider other physical examination domains that may assist us and may relate to the patient's presenting problem. So in this case, the patient's cardiorespiratory status and the cardiorespiratory examination are going to be very, very important, because certainly cardiac findings could play a significant role in the patient's presentation with his neurologic disability. So for instance, if this patient was noted to have a very loud cardiac murmur, then that could perhaps suggest etiology or perhaps an explanation for some of his neurologic symptoms. Furthermore, if we noted that the patient had evidence of an infection on his respiratory examination, then that might also further inform our thinking as to the differential diagnosis and the reason why this patient is presenting with the symptoms that he has. The neurologic examination is a very detailed and lengthy part of the physical examination in total and has several components, many of which are quite important. So we've already performed the first assessment, which is the level of consciousness. So essentially, is this patient awake and are they alert? The second is the patient's language and speech. Are they able to communicate? Are they able to speak? Following the language examination, we perform a cranial nerve examination. The cranial nerves are, of course, the nerves that innervate and supply the functions of the head and the neck. The motor examination, as well as the extremities, as well as the head and neck muscles, determining if the patient is able to innervate and provide strength to his extremity muscles. And then, of course, the sensory examination. Cerebellar examination as well assesses the proprioception and the coordination of the extremities. And then there's extinction and neglect, which is a little more complicated, but pertains to the ability of the patient to notice and recognize objects in his or her area of intention or visual field. All right. So to drill down a little more onto each of these individual bullet points, the level of consciousness is the degree of alertness or consciousness of the patient. If the patient is conscious and able to communicate, is the patient oriented? And a good way to start this is to ask them if they're oriented to who they are, where they are, and what time and year it is. If the patient is conscious, we can ask them to perform a one-step command to understand if they can understand you and grasp things that you're asking them to do. So a one-step command might be to shake my hand or to pick up this pen. Assessing the language or the speech of the patient is important. And of course, it's first necessary to determine if they can speak, as in our case, the patient is unable to speak. But you can ask the patient to name objects and read written sentences. So perhaps present the patient with a pen and ask them to name the pen and what the name of the object is, and then to read sentences. And this can give us a good idea if the patient is able to process commands as well as identify objects and read. We can also evaluate at this point the production of speech, and that's very important because some patients will manifest what we call dysarthria, or an inability to speak clearly. Following the evaluation of speech and language, we can perform a cranial nerve examination. And that has several components, first of which is an assessment of the patient's gaze. As we know, the extraocular eye muscles are innervated by the cranial nerves, and so assessment of the horizontal extraocular eye movements is important and can give us a sense as to the function of these cranial nerves. We can also assess the patient for the presence of a facial palsy, and we do that by assessing the symmetry of the face. So does the patient have a facial droop? Is the innervation of the patient's face symmetric? When you ask the patient to close their eyes, do the wrinkles on the patient's forehead and around their eyes and their orbits, do these seem to be symmetric? And similarly, when we ask the patient to show us their teeth, do their lips and the labial folds and the creases around their mouth appear to be symmetric from the right to the left? We can as well assess the patient's visual fields, and this is important because, of course, the optic nerve is a cranial nerve, and this will allow us to determine if the patient has a visual field cut. And we can perform this by essentially holding up our fingers, 2 fingers, 3 fingers in different parts of the bilateral visual fields and determining if the patient is able to see them and tell us how many fingers we have out. The motor and sensory examination is also very important. In the motor examination, we assess the upper extremity strength, and you do that by essentially having the patient lift their arm or leg against the force of gravity and see how long they can hold it. Many times we count the 10 as they hold it in the air, and that allows us to compare one side to the other. And this is performed for the bilateral upper extremities and the bilateral lower extremities. So in the sensory examination, we perform that, for the bilateral upper extremities and the bilateral lower extremities. You can either use light touch or pinprick, and what sometimes we do is we bend a paper clip and see if that patient can sense that on the right side to the left. And of course, we're trying to determine if there is symmetry from the right to the left. We also perform an evaluation of the cerebellum, and as I mentioned before, the cerebellum is the part of our brain that assists us in coordination. So the way we do that, of course, again, we do assess the bilateral upper and lower extremities. We perform the finger-to-nose maneuver, in which the patient is asked to touch the emergency care provider's finger and then to touch their nose, and to do this repetitively. And in so doing, we can get a gauge of the patient's coordination of their upper extremities. To assess the lower extremities, we perform a maneuver called the heel-shin maneuver, in which the patient takes one heel, places it on their opposing knee, and then allows that to slide down to the ankle along their shin on that side. And they perform that on both sides. And this is also a measure of lower extremity coordination and the use of the cerebellum. And then, of course, we have extinction and neglect. And what extinction and neglect are is essentially the loss of a patient's attention to an object or an item as it passes from one side to another. Extinction and neglect can come in multiple sensory modalities. You can have cutaneous neglect, visual neglect, and auditory neglect. This can be hard to distinguish from other deficits like visual field deficits or other sensory deficits. And of course, we do assess this bilaterally as with the other components of the neurologic examination. So as we've completed our neurologic examination of the patient, I think it's a good time to reflect on what we found. So we've noted that our patient is alert, but they're unable to form speech or communicate with us in any way. We've also noted that the patient has right-sided hemiparesis, and what that means essentially is that they are unable to move their upper extremity or lower extremity on the right side, even to resist gravity. We are unable to assess their sensory examination, and this can sometimes happen. This patient is unable to communicate with us. Other patients may be critically ill, or they may be confused or even unconscious, and thus parts of the examination where we need to ask the patient about their sensory perception, or in which we have to ask the patient to follow commands, we may not be able to complete these parts of the examination. And indeed, in our patient, we are noting as well that this patient not only is not able to communicate, but is also not able to follow commands. And if you recall, we also noted that the cardiopulmonary examination would be a good, another part of the physical examination to be very important in our individual. And in this case, we've noted no abnormalities. The patient seems to be breathing well, has a good pulse, and has no cardiac murmurs. All right. So we've completed our sample history. We have also performed a brief assessment of the patient, including the neurologic examination and the cardiopulmonary examination. And now at this point, it's appropriate to think about what is potentially contributing to the patient's presentation. There are multiple diagnoses, both neurologic and non-neurologic, that can contribute to the findings of a neurologic disability. In our case, the patient's unable to communicate or follow commands and seems to have a deficit in the strength of his right side. But certainly any kind of altered mental state, including confusion, unconsciousness, or focal neurologic sign of any kind, can have non-neurologic causes, some of which are listed here. So for instance, infections can certainly cause neurologic findings, focal neurologic signs. So for instance, patients with meningitis can present with neurologic findings. Also patients with infection of the brain parenchyma itself, like an encephalitis or perhaps a cerebral abscess, can also present with focal neurologic findings. Patients with non-neurologic infections as well can present with neurologic findings. So perhaps, for instance, patients with sepsis can present confused or unconscious, and this can oftentimes be mistaken for a neurologic presentation. One of the most common mimics of stroke or neurologic disease is low blood sugar. Patients who are diabetic and who take insulin for one reason or another may eventually have low blood sugar. This can present in a variety of ways, from mild dizziness and perhaps diaphoresis to unconsciousness and seizure. And as a result, as we'll discuss, checking the blood sugar will be a very important component of this patient's initial assessment. There are multiple metabolic diagnoses as well that can contribute to this patient's presentation. So for instance, low blood sodium levels can cause the patient to have seizure disorder, confusion, or unconsciousness. And that is also true for other hormonal deficiencies, such for instance, thyroid disorders can present with neurologic symptoms. Quite obviously, a very common presentation for patients with either confusion or neurologic findings is substance abuse. Patients who consume alcohol or other illicit substances, or even substances such as herbal remedies that may have psychoactive effects can present with neurological or psychiatric presentations which may mimic stroke. Traumatic injury is yet another possible contributor to patients that we have presenting with neurologic findings. Many times patients have some trauma that was remote to their presentation, maybe either by hours or even days, but yet have sustained significant cerebral injury that is contributing to their presentation. As well, psychiatric disease can often present with focal neurologic findings or more diffuse neurologic findings, such as confusion or perhaps altered level of consciousness. And it's important to keep that in mind in patients. Oftentimes the history or the medication list will reveal the presence of a psychiatric condition. Many seizures, actually, in the postictal state, patients will be quite obtunded and confused, and this can mimic stroke. Further, Many patients, even after they've recovered from their stroke, can have persistent neurologic disability, and this can be focal and can mimic stroke symptoms. Brain tumors, depending on where they are in the brain, can of course also produce focal neurologic findings or even more diffuse findings such as seizure or altered level of consciousness. Lastly, migraine headache. While typically migraine headache produces a simple headache syndrome, many times in more complex migraine syndromes, patients can actually have focal neurologic findings which mimic stroke. So this is a fairly comprehensive list of non-neurologic considerations that we must keep in mind when we are evaluating a patient with focal neurologic findings. So as we consider stroke, we have to consider that we divide strokes into two domains. One is hemorrhagic strokes, another is ischemic strokes. Hemorrhagic strokes are strokes in which a blood vessel or perhaps an aneurysm in the brain has burst, leading to hemorrhage into the brain parenchyma. So you can see on this schematic, as well as the cut of the CT scan adjacent to it, there is hemorrhage into the brain parenchyma here, and this can produce, of course, a range of neurologic findings. Commonly, hemorrhagic strokes present with either seizure, severe headache, or depressed level of consciousness. As we consider ischemic strokes are a little different. Ischemic strokes are strokes in which there has been an obstruction or a blockage in blood flow to a particular region or territory of the brain. And this particular lack of blood flow can result in the focal neurologic signs that we note when someone has a stroke. This is more of the stroke syndromes that we think of. So in other words, weakness, loss of sensation to an extremity, or the facial droop and things we've discussed. So while not always possible, it can sometimes be possible to differentiate between ischemic stroke and hemorrhagic stroke in the history and physical examination. As you recall, hemorrhagic strokes oftentimes present with severe headache or seizure or depressed level of consciousness, whereas ischemic strokes more frequently present with a loss of function and the stroke syndromes that we will discuss in a moment. Stroke syndromes, or the presentation, the symptoms created by a stroke, are very much dependent on where the blockage of blood flow is. So as we discussed on the previous slide, a stroke is either a hemorrhage or a blockage of blood flow to an area of the brain. And when we talk about ischemic strokes, we're talking about a blockage where blood is not providing nutrients and oxygenation to a territory of the brain. Given the brain anatomy, there are several different arteries that frequently are obstructed, and the area of the brain that are serviced by these arteries is what determines the symptoms and the presentation of the patient. So we do see in some patients a middle cerebral artery stroke, or anterior cerebral artery stroke, posterior cerebral artery strokes, and then cerebellar strokes, lacunar infarcts, and brainstem strokes, and these all present with different specific syndromes in the stroke patient. So at this point, I think it's important to summarize what we've accomplished so far. So we've found our patient, we've noted the patient's symptoms and presentation, we've determined if the patient is sick or not sick. We've considered the patient and we've acted. We've also obtained a sample history. We have as well considered the different types of stroke, hemorrhagic stroke as well as ischemic stroke, and we've considered non-neurologic diagnoses or stroke mimics, and we've used these to develop a differential diagnosis for our patient. And in a second, when we commence part 2, we'll discuss more of the workup and how to address our patient.